Welcome to the Health Channel, all health, all the time. I'm Henry Guzman, a registered nurse and exercise physiologist with Baptist Health, South Florida. On our Healthy Living show, we are focusing on a gland that looks like a butterfly and produces hormones that regulate many functions in our body, the thyroid. 60% of people with thyroid conditions don't even know they have a problem. It's an important topic, and with us to explain how the thyroid works and what happens if it speeds up or slows down or doesn't work at all is Dr. Lara Paraskos, an endocrinologist with Baptist Health South Florida. Dr. Paraskos, welcome.
Hi. Thank you for having me. Happy to be here.
Unbelievably, that so many people are unaware that they have a thyroid problem. Is there a reason for this? Is this just not talked about as much?
Sure. I think the biggest reason that a lot of people don't realize why they have a thyroid issue is that a lot of the thyroid symptoms are very nonspecific. So, people can easily explain away a lot of the symptoms and not think of a thyroid problem. And so unless you're really looking for it or you're thinking about it or somebody else, your doctor, is thinking about it, you may not even know that you have an issue.
Right. So actually, before we dive into the thyroid,
Sure.
Maybe you can explain to the audience exactly what endocrinology is or what falls under that umbrella.
Sure. A lot of my patients that come to see me say, I don't even know what an endocrinologist does. So I always explain to them, endocrinology is the branch of medicine that deals with hormones in the body. So all of the hormones. The biggest thing we deal with is thyroid and diabetes as well. We deal with type 1 and type 2 diabetes. And then other hormones from the pituitary gland, the adrenal glands, as well as bone and calcium disorders.
Okay, wow, that's a lot under one umbrella. So let's focus in on the thyroid.
Absolutely.
Tell us what it is. It's this tiny little gland, but it regulates so much in our bodies. It's such an important organ, right? Can you tell us a little bit about the thyroid, what its function is?
Yeah, absolutely. The thyroid is a little butter-shaped gland in the base of the neck, and really what I tell my patients is it regulates how fast or how slow things go in the body. And so it regulates heart rate, how fast your hair comes in, how fast your skin turns over. It regulates how fast your intestines move, how your body temperature, temperature regulation. So it's very important gland, and it regulates a lot of functions in the body.
Right. So we actually have a nice nice little graphic here. So the first one, breathing. That's actually one of my favorite pastimes, is breathing. So obviously that's an important function. Can you kind of take us through the other things that it regulates?
And the thyroid, I think a lot of times we don't really realize what the thyroid does until there's a problem with it. But it can regulate breathing, the heart rate, essentially how fast or how slow the heart rate goes, body weight, because really the thyroid can regulate the metabolism and essentially how fast or how slow you burn calories. Muscle strength, the muscle weakness is a sign of some thyroid issues. Body temperature, some people will feel hot or cold, and body dysregulation. Cholesterol, that's actually an important point, that sometimes people that have very high cholesterol actually ends up having a thyroid issue as the contributing factor for their high cholesterol.
That's amazing that little gland regulates so much in our bodies, and most of us aren't even aware of what it's doing. So there's a connection there between the pituitary gland and the thyroid. Can you kind of tell us that relationship between the two?
Yeah, absolutely. What happens, the pituitary gland is, we say, the master organ in the body. And what happens is that releases hormones that essentially tell the rest of the body what to do. So the pituitary gland releases a hormone called TSH, and that stimulates the thyroid gland to produce thyroid hormone, which is a T3 and T4 are the thyroid hormones. And there's a feedback mechanism. So in somebody whose pituitary gland and thyroid axis is working perfectly, if one goes up, the other one goes down, and vice versa. If one is down, the other goes up, so they regulate each other. They provide checks and balances.
Gotcha. So they have to work in synergy to kind of so everything works. So we actually have a nice graphic that audience is looking at now. So if you can kind of take us through what we're looking at. And it's the thyroid. It looks like a little butterfly on there.
It does. So the thyroid is, like I said, right at the base of the neck. These are like the clavicle bones right here. And then this, right in the midline, that's the trachea, that's the windpipe. And the thyroid gland is this little butterfly-shaped gland right around the trachea. And there's two lobes to it. There's a right lobe and a left lobe here. And then they're connected in the middle by the isthmus.
Gotcha. And does each lobe have a specific thing that it does?
No, actually, the lobes, they all do the same thing. They're just, it's just anatomical, that the right and the left lobe are there.
Gotcha. And the pituitary, I know we can't see it on the screen, but it would be behind the head, right?
Yeah, exactly. So the pituitary gland is a little gland. It's a little like, it's about the shape of a garbanzo bean. And it lies right behind the eyes, right there.
Gotcha. Oh, okay, great, great graphic there. So, Dr. Paraskos, I understand that women in general are more prone to having thyroid issues. Is that the case? And if it is, why is that?
Sure, yeah, women are definitely more likely to have thyroid issues. The reason is that most thyroid issues are secondary to autoimmune diseases, and women in general have more autoimmune diseases than men.
Gotcha. And are they more prone after pregnancy? Is that a correct statement?
Yeah, it's funny. So we see a lot of thyroid issues after pregnancy, and you know, I think what happens during pregnancy, your body downregulates the immune system so that you tolerate the pregnancy, and afterward things can go haywire. So a lot of times we see things, you know, presenting after pregnancy. It also may be that women are seeking medical help more. You know, they're seeing doctors more right during and after the pregnancy, so we may catch it more after the pregnancies. But it could be something with the autoimmune regulation why we see so much more after pregnancy.
Yeah, so that's a good point, that a lot of people may not know they have an issue with their thyroid. Yeah. So there's a simple blood test that can be ordered. Can you tell us a little bit about that blood test?
Sure, yeah, the blood test that we order is the TSH, which is actually the hormone that we were talking about that comes from the pituitary gland. It's a very sensitive test, and if that's normal, then the thyroid should be functioning well, and if it's abnormal, it will tell us that the thyroid is over or under functioning. The funny thing about the TSH is that it's the opposite of the function of the gland. So a lot of times people can get confused by that. A TSH that's high usually indicates hypothyroid or underactive thyroid, whereas the TSH that's low can indicate hyper or overactive thyroid.
Gotcha. So that can get a little confusing.
It can.
Right?
It can. Yeah, absolutely.
So is this blood test part of an annual checkup? Is that something that's normally done for a well check, or?
Usually not. So usually the TSH is not something that's automatically included in an annual checkup. The guidelines do recommend, especially in women, to start checking the thyroid at least once every 5 years, starting at age 35. But it's not something that they do on a yearly basis unless you know, you ask for it specifically or you have symptoms that may be concerning for thyroid issues for the doctor.
Gotcha. So is it a good idea just to have that conversation with your primary care to say,
absolutely.
Listen, I'm having, you know, I'm feeling a little tired, or whatever. That's a very common thing. Is that appropriate to say, hey, doc, you know, can you check my TSH level? I've been watching this great show with great information. Can you order this test? Is it a simple test to order? Is it
Yeah, it's a very simple test. It's a blood test, and it definitely is worthwhile, especially if you're having any concerns, just to have the levels checked. It's a safe and easy blood test, and usually the results come back fairly quickly.
And as far as, so you have a thyroid issue, and we'll get a little bit more into detail because we have the hypo and the hyper, right? So a little history behind some of the medication that's been prescribed over the years. Chemist Edward Kendall on Christmas Eve in 1914 became the first to successfully crystallize a thyroid hormone in the lab. Let's find out how he did this.
Levothyroxine, the name for synthetically made thyroid hormone, is the most commonly prescribed medication in the United States. There are millions of patients that take thyroid hormone.
The thyroid, it's a butterfly-shaped gland that resides just below the Adam's apple. Unless it acts up, you probably never give it a thought. Problem is, it acts up for a lot of people.
About 8 to 10% of women in the United States will have thyroid disease or dysfunction at some point in their life, and 2 or 3% are men, perhaps more. And it would be
Mayo Clinic's Dr. John Morris III is a gland specialist called an endocrinologist. He says a thyroid's main purpose is making essential hormones.
Thyroid hormone is important in the metabolism of basically every cell, every tissue, every organ in the body.
A century ago, Dr. Morris says a lot of patients coming to Mayo Clinic in Minnesota were seeking help for problems caused by thyroid hormone imbalances, often causing goiters, a swelling in the neck. He says performing surgery for thyroid goiters kept the Mayo brothers quite busy.
And it was in fact that early business of the Mayo Clinic that was the impetus to bring Edward Kendall to Mayo Clinic. because there was a lot of thyroid disease here.
Edward C. Kendall was a young chemist from New York who was obsessed with unlocking the thyroid secrets. So, in the southwest corner of the brand new and aptly named 1914 building, Kendall set up his lab and made good progress during his first summer and fall at Mayo Clinic, purifying thyroid compounds.
And actually, as the story goes, he came in on Christmas Eve in 1914 to do one additional round of purification and to try to crystallize this newest preparation. On Christmas morning, he went in to the laboratory and he had crystal powders of purified thyroid hormone. The first time the hormone from the thyroid that we now call thyroxine had been purified.
The discovery is the reason so many people have this potentially life-saving medication today.
That's fascinating. I had no idea where this medication came from, how it got started. And I'm going to guess a lot of the medications and procedures that we do today came about because of people who are so dedicated to their specific field, and they came up with these new procedures and medications. So levothyroxine, did I pronounce that correct?
That's perfect.
That's sort of the generic brand for a synthetic hormone?
Correct.
That most patients get.
The levothyroxine is essentially the synthetic form of T4, which is the main thyroid hormone that your body produces. And the generic is the levothyroxine, and then the brand is called Synthroid.
Gotcha. So we haven't really gotten into the specific type of thyroid issues, where this particular medication is for hypo.
Correct.
Correct, right? And I'd like to talk a little bit more about that when we get back from break. So getting your thyroid checked is crucial because it's a gland that controls so many aspects of your body. But after testing, what do you look for? When we come back, we're going to talk about different conditions associated with the thyroid. You're watching the Health Channel, All Health All the Time, South Florida PBS. If you have a question for the doctor, please call in using the toll-free number 855-796-4475 and visit our website, allhealthtv.com, where you can watch a live stream on the Health Channel, submit questions for the experts, and watch videos from previous shows. We'll be right back.
I may look like all the other dogs, but I was born for a purpose, to one day be your companion, your eyes to see the world. I'll be your courage, your friend. With me, you'll find new freedom and hope for a better future. A dog I'm not. I'm a Southeastern guide dog.
A brain aneurysm doesn't care that you have important meetings. It doesn't care that you have to drop your daughter off at ballet and your son off at soccer practice. So if you suddenly experience the worst headache of your life, sharp pain behind your eye, and blurry vision, seek immediate emergency care. The Lisa Calagrassi Foundation, shedding light on brain aneurysms. Learn more at lisafoundation.org.
Heiny, tushy, badonkadonk, call it what you want, but talk to your doctor, because the American Cancer Society says colon cancer is a leading cause of cancer deaths in the U.S. I was diagnosed with colon cancer, but I might have avoided it completely if I just had my keister checked. So get off those juicy doubles and go get your rump shaker screened so you can say you literally saved your own. Can we change padonkadonk?
Families come in all sizes and shapes. Sometimes your friends are your family by choice, or sometimes you're just stuck with Uncle Charles. But what we know is that you want to protect the people that are close to you, but the flu can unravel everything. Your flu vaccine protects you and your family. No matter what draws your family together, protect yourself, protect your family. Everyone needs a flu vaccine.
A brain aneurysm can strike you when you least expect it, plunging your entire world into darkness. But if you know the warning signs, you're much more likely to survive. If you suddenly experience the worst headache of your life or sharp, sudden pain behind your eyes, do not ignore it. Please seek immediate emergency attention. It's time to shed some light on brain aneurysms. You gotta know the information.
The Lisa Colagrassi Foundation, lisafoundation.org.
And welcome back to the Health Channel. I'm Henry Guzman, a registered nurse and exercise physiologist with Baptist Health South Florida. And we're talking about thyroid conditions with Dr. Lara Paraskos, an endocrinologist with Baptist Health South Florida. If you have a question for the doctor, here's your chance. Please call in using the toll-free number 855-796-4475. We would love to hear from you. So we were just talking about some of the hormones that the thyroid gland releases. I'd like to talk a little bit specifically about one of them. Kind of the two main ones are hypothyroidism and hyper. Let's talk a little bit about hyperthyroidism. Can you tell us what that is exactly?
Sure. Hyperthyroidism is when the thyroid gland is overacting or producing too much thyroid hormone.
Gotcha. So when a patient comes in and asks you, all right, doc, sounds, you know, right, but I still don't understand. What do you tell a patient when they tell you, I'm not quite sure what hyperthyroidism, why do I have this?
Sure, so hyperthyroidism is a common condition with the thyroid where it just produces too much thyroid hormone, and there are a few different reasons to have it. One reason is something called Graves' disease, which is autoimmune. Sometimes you have a thyroid nodule that's producing too much thyroid hormone. Sometimes you have a few different thyroid nodules that are producing thyroid hormone. And there's another condition where it's like an acute inflammation of the thyroid called thyroiditis that can also cause hyperthyroidism. So there's a lot of different reasons to have the overactive thyroid gland.
Gotcha. Can you tell us what nodules are?
Sure. A nodule is growth in the thyroid. So it's just a few cells that grow too big and are like a little, I tell patients that there's like a mole on the thyroid, like a little skin mole on the thyroid almost.
Gotcha. We actually have a nice graphic here we're going to put up with some of the symptoms of hyperthyroidism, and we're seeing things like anxiety, irritability and moodiness, nervousness, sweating, hand trembling, hair loss. Wow, that kind of sounds how I feel when I'm playing poker and everybody knows that I have a bad hand. That's my tell.
Absolutely.
So, Doc, can you tell us a little bit about each one of this and why it's affecting why these symptoms are coming about?
Sure, absolutely. You know, the thyroid, again, controls how fast everything goes. So when you think about all of these symptoms, everything is going really fast. So the nervousness, the hyperactivity, everything in your body is just like going. Sweating is because you're feeling very hot. You feel, again, the shaking, the hair loss because the hair follicles just come out quicker. Additionally, other symptoms that patients may complain of is trouble sleeping. Insomnia is a very big symptom of hyperthyroidism, as well as weight loss.
So with hyperthyroidism, does the thyroid actually get enlarged?
Sometimes
is that
it can.
Sign?
Yeah, absolutely. Sometimes it can. Especially if it's working too hard, it's like a muscle almost. So it, if it's working too hard, it can get very big and get enlarged.
Gotcha. So is hair loss part of this, or is this getting into more the hypo?
So it's a good question. Hair loss can be both. Hair loss can be hyper or hypothyroidism. Absolutely.
So what happens exactly with this? Because this might be a symptom or a sign that folks could look out for. So is it just a thinning of the hair or actual hair loss, like alopecia?
Right, it's more about an alopecia, so the hair just falls out quicker. Now what happens with hair is that it grows in cycles. So there's a growth phase, a maintenance phase, and a falling out phase. And when the thyroid is off, the phases are different. So the phases can be shorter or longer. And so that's why you can see hair loss with both hypo and hyperthyroidism.
Gotcha. And just for clarification for our audience, we threw in a fancy word there, alopecia.
Sure.
Can you tell us exactly what that is?
Absolutely. Alopecia is just a fancy word for hair loss. And there's a few different types of alopecia. There's alopecia caused by certain medical conditions. There's also autoimmune alopecia, where you have an immune reaction that causes alopecia. There's androgenic alopecia, which is from testosterone. So there's a lot of different causes for alopecia, and the thyroid is one of them.
Gotcha. So hyperthyroidism. I know it gets a little tricky there. We're talking about hyper now, and it's important to know the differences between the two, especially if you're suffering from some of these symptoms, so you can kind of explain these to your doctor. Is there a medication for that specifically?
Yeah, absolutely. Once we diagnose hyperthyroidism, there are medications that can help to normalize the thyroid levels. The medications that we have, the most commonly prescribed one is called methimazole. Then the other medication we have, which we really only use in pregnant women in the first trimester, is something called PTU.
Gotcha. And how do you dose the patient? Is it by weight? Is it by?
Sure. Yeah, it's actually, it can be tricky. What I tend to do is I look at how severe the labs are off, and then based on that, I can usually guess at a dose, and then the patient would have to come back a few weeks later to check the dose to see if it's an appropriate dose or not.
Okay, so that actually leads me to my next question. So you go in, you explain to them what's going on, you tell them the treatment plan.
Yep.
So what is afterwards look like? What's the post-visit look like, or what does the patient have to do afterwards?
Yeah, absolutely. So what happens with hyperthyroidism, once you're started on medication to normalize the levels, patients usually feel better in the first few weeks. And they're very thankful because hyperthyroid patients tend to feel very miserable with their symptoms. And so typically in the first few weeks, they feel better. Then they come back and we check their levels and we adjust the dose. This medication is not something that we usually keep people on for a long term. So if the hyperthyroidism improves and we can come off medication, that's wonderful. If it doesn't improve on the medication, then we have to do something we call definitive therapy or definitive treatment, which essentially is radioactive iodine. So it's a radioactive version of iodine, which is what the thyroid hormone is made of, that will kill off the thyroid. Or in certain cases, we may need to do surgery to remove the thyroid, like we saw in the video at the Mayo Clinic, what they were doing before.
Gotcha. So medication's one way, and earlier we spoke about how to find out what's going on with the thyroid. Is there other ways besides a blood test? I know sometimes we mentioned that it can get enlarged. Is that one way also to kind of, that might be a red flag?
Yeah, absolutely. It can definitely be a red flag. Anytime we have somebody that presents with a goiter, which just is a fancy term for a big thyroid, or a thyroid nodule, or any enlargement in the neck, we always check a thyroid function panel to make sure that the function is normal.
So first, you would actually kind of feel around and see if the thyroid is feeling a little enlarged, and that would kind of prompt you for the blood
to do
test.
blood work, exactly. Something that I tend to tell my patients, especially with thyroid nodules, is that the function and the structure of the glands are not always connected. So you have sometimes a hyperthyroid or hypothyroid patient, and the gland may be totally normal. So it doesn't always have to have a relationship, but a lot of times it does, and so that's why we always check the levels. And if you come in with hyperthyroidism, we may do an ultrasound to see if there's a nodule, to see if we can figure out why is the reason, what's the underlying reason for the hyperthyroidism.
So you made an interesting comment, because I think it's a little different with the hypo when we get to that possibly they can come off the medication when they're hyper, depending on what's going on. Can you explain that mechanism? Why is that possible?
Yeah, absolutely. So the hyperthyroidism, the ones patients that can come off medication, is usually caused by Graves' disease, which is autoimmune. And what happens is your body makes these antibodies that stimulate the thyroid to produce extra thyroid hormone. And sometimes with medications, the immune system can calm down and the antibody levels can decrease, and it doesn't stimulate the thyroid as much, and we're able to come off medication and maintain normal thyroid levels.
And the thyroid could just go back to normal?
Sometimes, yes, it's possible.
Okay.
It's not always, and we always hope it can, but a lot of times it doesn't, but there's always a chance that we can come off medication with hyperthyroidism.
And is there anything a patient can do to help that along? Or is it just, if the medication works, it works. If it doesn't, it doesn't?
Exactly. I wish there was a better answer to that question, but there really isn't. It's one of the things that we just have to wait and see what happens. There's really nothing to do that can help it one way or another. I mean, I think just general advice for all patients is just to try to eat well and stay healthy. Make sure that you're trying to avoid processed foods and preservatives, and try to make sure you're exercising and getting enough sleep, and just in general, that's a better way, of living, and you may feel better with that. But does that mean that you're going to influence your thyroid disease at all and your hyperthyroidism at all with diet? Most likely not. I wish there was a better answer for that, but there's not.
So when we get the blood test, I don't want to confuse folks too much, but when you get the labs back, there's a range specifically.
Yeah, absolutely.
So can you take us through what that range is and what you're looking for as far as, is it getting better or is it getting worse?
Sure. So what we look for in hyperthyroidism is the TSH is the main thing that we're looking at. The range of TSH goes from about 0.4 to 4, and obviously every lab is a little bit different, but that's a general range. And remember that hyperthyroidism or overactive thyroid, the TSH is low, and so we're looking for a TSH that's below 0.4. Additionally, when we diagnose somebody with hyperthyroidism, we look at the T4 and T3 levels to see where they're at and to make sure that they're corresponding with that low TSH level. That's ruling out something that's very rare, but we always like to do it just to make sure we're not dealing with something else. And then when you're on medication, we look at everything. We look at the TSH, and then a lot of times we'll also follow the T4 levels. And the reason we do that is because the TSH can take about 6 weeks, 6-8 weeks to change. And so if you're following somebody quickly and you want to adjust medications quicker, a lot of times we'll focus on the T4 levels because those will change faster, and we can make faster adjustments on the medication, evaluating that.
Great. And for our audience members that want to get into the weeds just a little bit more, can you tell us a little bit of the difference between TSH, the TSH level,
Sure.
the T3, and the T4?
Yeah, absolutely. So the TSH is the hormone that's produced by the pituitary gland, and the T4 and T3 are the two hormones that are produced in the thyroid gland. And so in hyperthyroidism, the TSH is low, and the T4 and T3 levels are going to be high. They're going to be elevated.
Gotcha. So just to kind of recap, hyperthyroidism, your TSH is actually low. So it's
Yes.
opposite of what you think it would
Absolutely.
be. And then hypo, you're getting a high TSH.
That's exactly right.
Okay. And it sounds simple, but it's very
not.
easy to forget.
It's even hard for sometimes when you're looking at labs, your first instinct is to think, oh, my TSH is high, I have hyperthyroidism.
Right.
You know, so it can be challenging, but.
Nice. So up next, we focus on another thyroid conditions with symptoms like trouble sleeping and dry skin and hair. Stay tuned. You're watching the Health Channel, all health, all the time on South Florida PBS. If you have a question for Dr. Paraskos, please call in using the toll-free number 855-796-4475 and visit our website, allhealthtv.com, where you can watch a live stream of the Health Channel, submit questions for the experts, and watch videos from previous shows. We'll be right back.
Keeping your kids healthy is the first step to protecting their dreams. When you keep them safe, there's no limit to how far they can go. Nothing is out of reach. No mission? Impossible. Give your son or daughter a better chance to see their dreams come true. Give them the HPV vaccine at age 11 or 12 to prevent HPV cancers later in life.
When you lose hope, I'll be there. When your world goes dark, I'll lead the way. When you come back home, I'll be by your side. I'll give you hope. I'll give you confidence. I'll be your freedom. I know I'm little now, but when I grow up, I'll be your Southeastern guide dog.
Hi, this is Terry Bradshaw here to remind you that rheumatic diseases like rheumatoid arthritis and lupus are important to know about. If you're like me, you don't have time for flare-ups to slow you down. That's why I've taken the American College of Rheumatology's pledge to live well with rheumatic disease, and you should too. Things like eating healthy, staying active, not smoking, and managing my stress keep me going. Visit simpletest.org to take the pledge to live well.
Good night, stars. Good night, air. Good night, noises everywhere. Time to say good night.
Cancer doesn't run in my family. That really was the farthest thing from my mind. I've been an athlete my whole life, and I work in sports, so my mindset was just, let's fight. So our stories are all unique, so whatever you're going through, ask questions, get information, and be involved. Don't ignore the signs. Join the fight. I'm Tony Beasley, and I'm a stage 2 colorectal cancer survivor.
Welcome back to the Health Channel. I'm Henry Guzman, a registered nurse and exercise physiologist with Baptist Health South Florida. We're talking about thyroid conditions with Dr. Lara Paraskos, an endocrinologist with Baptist Health South Florida. If you have a thyroid question for the doctor, here's your chance to call. Call in. Please call in using the toll-free number 855-796-4475. We would love to hear from you. So we just went over some symptoms for hyperthyroidism. We'll recap a little bit. Hyper, TSH low.
Correct.
Hypo, TSH high.
Yes, absolutely.
And it's confusing, I know it is, but let's talk a little bit about hypo. Can you tell us a little bit about the symptoms associated with hypothyroidism?
Sure, yeah, hypothyroidism is essentially, the symptoms are the opposite of hyperthyroid, where your thyroid is, so hypothyroid is where your thyroid is slow. And so everything in your body is kind of going very slowly. So you can have, big symptoms are difficulty concentrating, feeling very tired or fatigued, dry skin, brittle nails, the nails are breaking all the time, hair loss, the hair can be thin and brittle, and it can fall out very quickly. It can cause depression, feeling very cold, constipation as well, and a lot of patients also complain of weight gain with hypothyroidism.
Right, interesting. Those are all the same symptoms I feel after I pay all my bills at the end of the month.
Exactly.
So are there any other symptoms that we should be looking out for when it comes to hypo? We had a nice graphic up there. Anything else that we should be looking out, a little
Sure.
red flag?
The biggest things that I saw that weren't on that graphic were the weight gain. That was the biggest thing that was on there. And the fatigue, really. Patients complain a lot of fatigue and brain fog, so difficulty concentrating. That's a very common complaint of hypothyroid patients.
So weight gain, I know there's been a lot of talk in previous years about it being a strong correlation with having thyroid issues.
It definitely can.
So that alone, should that prompt you to ask your doc, hey doc, I've put on a few pounds, can you check my TSH? Is that,
Yeah.
should you have other symptoms in there
I mean,
well?
listen, the fact is that weight and obesity and being overweight is a very prominent problem in our society. And so there are so many different things that contribute to weight and weight gain. And the thyroid is one of them. So I do think that it's important if you are gaining weight to check your thyroid and just make sure that it's normal. Most likely it's going to be normal, but it's always good to rule it out and make sure, because we do have good treatments for it if it does end up being the case. And just a little quick thing about weight and thyroid, you know, a lot of patients come to me and they're 20 or 30 pounds overweight and they think, oh good, I have a thyroid problem, it's gonna fix everything. But it usually doesn't. The thyroid, when we talk about weight gain with thyroid, it's usually only about 5, 8, 10 pounds, something like that.
Okay, so that's a great tip if you guys are listening. So unless it's within that range, it's probably not the thyroid. So there's another symptom up there that caught my attention, depression. So can you tell us a little bit about how that comes into the picture here?
Yeah, absolutely. So the thyroid, it really contributes to mood, and you know, a slow thyroid can make you feel sluggish and can contribute to depression. And so that's also something to consider if you don't have a history of depression and you become depressed, or if you have depression already and the symptoms are getting worse. It is important to check your thyroid level and make sure that it's stable and it's in normal range.
Yeah. So depression is a very serious thing, and
yeah, absolutely.
Specifically for folks with thyroid issues, what are some of the signs and symptoms? Because what should you be looking at? Because we all have days we get up, we don't feel so great, you know, we had a fight with a friend or something happened at work, and you might feel a little blue. So at what point do you think, you know, we should look out for actual depression, or how to differentiate between depression and actually feeling blue?
It's tough. I mean, it's a very difficult thing sometimes to make the difference between, just like a situational depression type of condition or actual clinical depression. I think, listen, if you ever have any concern of anything, mental illness, depression, they're very serious concerns, and I think any inkling, if you're ever concerned, just see somebody and have an evaluation.
Yeah, that's great advice. So I'd like to talk a little bit now about the medication that Dr. Kendall, 1914, I think it was, on Christmas. How you forget that?
Yeah, that's amazing.
Right? Kind of brought this medication, levothyroxine, I believe is the generic term for it. Can you tell us a little bit about how that works with hypothyroidism? What is it that it's doing? Is it just replacing the hormone?
Yeah, absolutely. So levothyroxine is the synthetic version of T4, which again is the thyroid hormone that we make in our body. It's the most prominent one that we make. And so what the levothyroxine or Synthroid, what it does is that it just replaces what your body is not making enough of. So that's what I tell a lot of patients. It's not a medication that's stimulating one thing or blocking another. It's just giving you what you're lacking.
Right. So I mean, I'm just amazed that all these symptoms from this one little gland, and here this physician, 100 years ago, pretty much cured it for the most part, right?
Yeah,
you can live a normal life
yeah.
with just being on this medication.
Yeah,
that,
absolutely.
That's amazing. So when it comes to prescribing this medication, is it similar to the hyper? Do you kind of, is it person's weight? Is it,
yeah,
is it
a lot
little
of times
different?
it's a little different. So the hyperthyroid, I usually look based on the labs, which I also do look for with hypothyroid. But a lot of times what we'll do is we'll use somebody's weight and use a weight-based calculation to try to determine the appropriate dose for the patient to start on.
Gotcha. So a patient comes to your office, he's diagnosed with hypothyroidism, and you start him on a treatment plan. How often does this patient need to come back?
That's a good question. At the beginning, when we're first starting thyroid medication, we usually like the patients to come back between 6 and 8 weeks to check the levels. Once they're on a stable dose, depending on comorbid conditions, they can come every 6 months, even every year, once we have a stable dose.
Okay, so once you get them on a nice stable dose, you check their levels and it's doing fine. How often after that should they come check you out?
Once a year should be fine.
Once a year is plenty.
And what I usually tell patients is to watch out for some of the symptoms. And if any of the symptoms get worse, it's an easy test. Just come in, we'll check the levels and make sure that the dose is appropriate.
Gotcha. So when you start on this medication, what are some of the things that a patient should be looking for as far as maybe side effects or if it's working or not working?
Okay, it's a good point. So in terms of side effects, for the most part, the levothyroxine doesn't really have side effects. Of course, if you read the insert label, there's a lot of effects that you can see, but generally those effects are if you're taking too much or too little of the medication. So as long as the dose is appropriate, you should feel fine. You should have no issues with it. Something that we usually tell patients, especially when you're first starting off on levothyroxine, is to watch out for a very rare condition. It's another autoimmune condition. It's called Addison's disease or adrenal insufficiency. That's a disease of the adrenal glands. It's a condition of low cortisol. So a lot of times, because most thyroid is from something called Hashimoto's, which is autoimmune. There's a possibility of having other autoimmune conditions, and another common one is Addison's disease or adrenal insufficiency. And sometimes they can coexist. And when you start thyroid medication, you can unmask or worsen this adrenal insufficiency, and so you can precipitate what we call an adrenal crisis. So usually what I tell patients, and the only time you call me is if you can call me anytime, but the only time you call me, with the thyroid medication is if you take the medication and you feel worse, if you start getting low blood pressure, dizziness, headaches, nausea, vomiting, you start losing weight excessively, then you stop the medication immediately and you call me.
Yeah, and this is why it's so important for those follow-ups, especially when you're first starting in that medication. You got to find that sweet spot of where your levels are and the dosage. So, okay, your patient's on the medication and you got the right levels. Is there an appropriate way to take this medication? I know some medications, they have you take it on an empty stomach or after you eat, or they may cause some GI discomfort. Can you tell us a little bit about this particular medication and best time to take it and anything you should look out for to avoid any of those gastrointestinal problems or anything else?
Sure. Yeah, the Synthroid is, the Synthroid medication itself is very sensitive to the pH of the stomach stomach, and to any foods or substances such as calcium, soy products. And so the most important thing when you're taking this medication is that you take it in the morning on an empty stomach, and you want to wait at least an hour or half an hour to an hour before you eat or drink anything else. You take it with water. That's the biggest issue with the medications, because if you take it with food, the absorption may not be consistent.
Gotcha. So once you wait that hour, you can just go back to your to whatever meals.
For the most part. So there are some stipulations to that. The biggest thing being soy and calcium, because what I tell my patients is that the soy and the calcium, they can actually bind the thyroid hormone, and so it may further prevent the absorption of the medication. And so especially if you're having soy milk or you're drinking milk is okay, but it's like a calcium supplement, like if you're taking Tums or if you're taking extra caltrate, or if you're drinking a big soy latte, you really don't want to take those within 4 hours of taking the thyroid medication. But everything else you can eat is fine. Coffee is fine after half an hour at least.
Oh yeah, you can't take away coffee.
Exactly, I cannot do that. I'm not that mean.
So just to clarify, soy is okay as long as you wait
at
least the 4 hours. So for our vegan folks out there, our plant-based folks who are going, what am I going to eat?
Yeah, exactly.
The soy is fine. So coming up, Dr. Paraskos shares a story of what happened to her while taking an endocrinology training course. You're watching the Health Channel, All Health, All the Time on South Florida PBS. If you have a question for the doctor, this is your last chance. Come on, call in. Please call in using the toll-free number, 855-796-4475. Visit our website, allhealthtv.com, where you can watch a live stream of the Health Channel, submit questions for the experts, and watch videos from the previous shows. We'll be right back.
Children's Cancer Research Fund, we believe a world without childhood cancer is possible, but it takes all of us. And whether it's developing a groundbreaking treatment or helping a girl realize her dream, everyone has a role in a child's cancer journey.
People ask me how I keep a smile on my face. It's easy when you have so many great people that take care of you and support you.
To find out how you can be a part of a child's cancer journey and a part of the cure, visit childrenscancer.org, a public service message from Children's Cancer Research Fund.
Ovarian cancer is devastating and difficult to diagnose. It's often only caught in advanced stages, and 4 out of 5 women will see the deadly disease return.
I knew when ovarian cancer recurs,
it's often incurable.
It was terrifying, waiting for the other shoe to drop.
Until recently, following chemotherapy, women with recurrent ovarian cancer had to simply watch and wait for their disease to come back.
Well, we say,
not on my watch.
Not on my watch.
Not on my watch. Now, with maintenance therapies, women can extend their time in response and delay recurrence.
Knowledge and awareness of your choices empowers you
and gives you a greater sense of control.
Let's call for a change in ovarian cancer care.
The Not On My Watch movement empowers women facing recurrent ovarian cancer to take an informed and active role in managing their disease. Visit notonmywatch.com to learn more.
Welcome back to the Health Channel. I'm Henry Guzman, a registered nurse and exercise physiologist with Baptist Health South Florida. And we're winding down this hour's discussion on thyroid conditions with Dr. Lara Paraskos, an endocrinologist with Baptist Health South Florida. If you have a question for the doctor, call. Come on, guys. Our toll-free number, 855-796-4475. We would love to hear from you. Thyroid cancer is becoming an epidemic, not only in the United States, but throughout the world. And the question is, how much surgery is appropriate? When Leana Santos, 41, was told that an abnormal growth in her thyroid was cancerous, she had a tough time registering what she had just been told. She had not experienced any symptoms, but her primary care physician referred her to an endocrinologist, after feeling a small nodule on her neck during a routine exam and ordering an ultrasound. The endocrinologist then had Santos undergo a biopsy before making the diagnosis of cancer. Let's take a look at her journey.
I went to see my primary doctor, Dr. Lara Paraskos, last December 2016. And she did a physical examination and she found out something on the neck. She recommended me to do an ultrasound, as I did. But later she recommended me to see the endocrinologist. Dr. Krieger called me and explained everything about the results. She mentioned the word cancer. That's very tough. As soon as she told me, she started talking to me about Dr. Urosman, so don't worry, he's coming, he's able to help. But I didn't listen to anything. I was like thinking on that word. That's very tough.
I had contact with her endocrinologist here, Dr. Diane Krieger, who's just fantastic. And we talked about the patient, and she had a small nodule. I knew she would do well with surgery. So I actually called her and chatted with her on the phone. So there are 4 kinds of thyroid cancer. By far, the most common is papillary thyroid cancer, which is what she had.
He explained everything again. He asked me if I have any questions. That made me feel very like I'm in good hands. Someone is trying to help.
She was actually my first patient when I came down here. I felt like I knew her before I ever had met her.
I met him here at Miami Cancer Institute, and that was funny because when I met him, I felt like I know him.
Thyroid cancer is really becoming an epidemic, not only in the United States, but throughout the world. And the question is how much surgery is appropriate for most patients? In her case, and in concert with her endocrinologist, we decided we just had to take out the thyroid lobe and not the whole thyroid gland. And in addition to that, she will not require radioactive iodine treatment. So those are all really nice things. And even better for her, she doesn't even need thyroid hormone. So she's living normally with her own thyroid gland inside without taking thyroid hormone. So it's kind of the best of all worlds for her.
I didn't have any pain at all. I waited like 3 days after surgery to start working again. But he told me that was perfect. As a doctor, as I told you, he's prominent. He's also a really, really good person. His human being is something that made the difference for me and my family.
Wow, what a great story. So glad she shared that with us. So a lot of people talk about, obviously cancer is a very scary word. Can you tell us a little bit about the thyroid specifically in cancer, risks involved, or are there things we could do to avoid it, or is it just something that some people are more prone to?
Yeah, thyroid cancer is becoming increasingly prevalent, especially in the United States. And most people have no risk factors for thyroid cancer, but there are some things to keep an eye on. First thing is if you have a family history of thyroid cancer. If you're a female, females have a higher chance of thyroid cancer than men. If you have exposure to radiation in the head and neck, and that doesn't just mean dental X-rays, because a lot of my patients say, oh, I get dental X-rays, and they forget to put the thyroid thing over, which they always do. But it's really somebody who's had, a lymphoma, Hodgkin's lymphoma, and had thymic radiation, because the thymus is right here, and it's right next to the thyroid. So if you have had radiation to the area, if the residents in Chernobyl or not Fukushima, those are patients that have had excess exposure to radiation. Those patients are more at risk for thyroid cancer.
Right, and there are so many unknowns that we just don't know
absolutely.
about, chemicals and exhaust fumes and things that we just don't know. So there are other potential causes for these nodules as well. Can you kind of comment on this as well?
Yeah, sure, absolutely. So thyroid nodules are very common. They're even more common than thyroid cancer, especially in women. More than half of women get thyroid nodules in their lifetime. And most of those nodules, about 90–95%, are nothing to worry about. Some causes of thyroid nodules or enlarged gland would be iodine deficiency. But again, usually that doesn't happen in the United States. But worldwide, that is the most common cause of an enlarged gland or thyroid nodules. If you have a cyst, a cyst is just really a nodule that's filled with liquid. The nice thing about cysts is that they're usually benign. So if you have a thyroid cyst, it's less likely to be a thyroid cancer. Thyroiditis, which is an immune, an immune reaction in the gland, it causes a lot of inflammation in the gland, and you can get nodules that kind of come and go, and it's related to the immune reaction. And then multinodular goiter just means you have multiple thyroid nodules.
Wow. So, doctor, I understand you've had a personal experience with cancer. Would you share that story with our
Absolutely, yeah,
our
sure.
audience?
Of course I will. I was actually diagnosed with thyroid cancer a few years ago. Actually, when my daughter was 6 months old, is when I was diagnosed with thyroid cancer, and she's 5.
Wow, that must have been tough.
Oh, absolutely. I was in a training course at Mayo Clinic, something called Endocrine University, and I was actually late. I was taking care of my daughter, and I felt so bad. I was a few minutes late getting to the ultrasound practice, and so I felt really guilty. The whole group I was with looked at me funny, and I said, okay, I'll volunteer to be the first mannequin. So I said, okay, fine. So I laid down on the table, and they said, okay, they were teaching us how to do the ultrasounds, and I remember the technician, or it wasn't a technician, she was a surgeon. She goes, you know what you have, right? And I'm thinking to myself, what do I have? And I had no idea, because I never had a thyroid ultrasound before. I was healthy, I had no problems, I had no symptoms whatsoever. Why would I have a thyroid ultrasound? And I just kind of went along with it because I didn't know what to say. I was really in shock. I didn't want to be like, wait, what do I have? And then start, asking all these questions and getting into it while I'm trying to be the demo. And so I just kind of went along with it. And then when I got home, I said, oh my gosh, what is this? And she was like, this looks like thyroid cancer. And, she was telling everybody in the group, and I could not believe it. I really couldn't.
Wow, what a way to find out.
I know.
So did you have to go get another ultrasound just to be sure?
Oh, absolutely. I didn't believe it. I said, this could not be true. I mean, I'm an endocrinologist. How could I have thyroid cancer? I really could not. I couldn't believe it. So as soon as I got home, I called. I was still in my training. I was at University of Miami, and I called the chief of the division. I said, okay, I have this nodule and I need help. And so he kind of guided me through the process, and I went and had a formal ultrasound, and then after the ultrasound confirmed what the doctor already saw, then I went and had a biopsy done, which confirmed that I did have thyroid cancer.
And biopsy sounds scary.
It always does, yeah.
Can you tell the audience what exactly is involved in a biopsy when it comes to this particular diagnosis?
Yeah, sure. What happens at the biopsy, I always tell my patients, I say the anticipation is the worst part of the whole process. Because I think, like, you're right, when patients they think of biopsies, they think of these big needles, thick needles, and when you think of a needle going in your neck, it's probably, the scariest thing. Yeah. But what we do is we actually use a very small needle. We do something called a fine needle aspiration. And the needle we use is smaller than the one we use to take blood. So it's a very, very thin needle. Everything is done under ultrasound guidance. And so what we do is we find the nodule, and then we take the needle and just kind of guide it into it. The whole process takes 5 seconds, very quick.
And is it just a one-time deal?
Okay, it depends, right? It depends on where you go. So what happens is that when we're trained, and where I did my training, we're taught to do at least 4 to 6 passes on everybody. So to poke 4 to 6 times with the needle, no matter what. And that's what I had. I think they poked me 6 times when I had mine done. But the nice thing is that, now, and especially in our office, what we do is we have a microscope available. And so what we can do is in real time, we make a slide, we stain it, and then we can check for adequacy of the specimen. And so a lot of times, doing that, we can just do 1 or 2 passes to get enough cells to make an accurate diagnosis.
So that sort of confirms the diagnosis, the biopsy. So what's step 3?
Step 3, after you have the diagnosis of thyroid cancer, is to see the surgeon, because really the treatment is surgery. A lot of patients, again, when we talk about cancer, the first thing is, oh my gosh, I'm going to have chemotherapy, I'm going to have to radiation therapy. But with thyroid cancer, for the most part, surgery is the biggest part of curing thyroid cancer. And like you saw in the video with Dr. Udelsman, who is an amazing surgeon. We love him in our office. We send most of our patients over to him. He's a great, great doctor. And he's right, we try to save as much of the thyroid as possible. In the past, what we used to do is, if you had thyroid cancer, you would have the whole thyroid out, and you would get something called radioactive iodine as a treatment. But nowadays, we're trying to do less surgery to try to preserve as much of the thyroid as we can.
So, Dr. Paraskos, having experienced this personally, has this influenced in any way how you practice medicine now when you see patients having gone through this experience yourself?
Yeah, absolutely. It really gives me a personal perspective on what patients are going through, especially when you hear the word cancer. Like I said, I'm an endocrinologist. I'm trained for this, so I know what to expect. And even when I had the diagnosis, it still hit me, and I said, I cannot. How is this happening? And so I know how it feels. I know how it feels to have the biopsy. So when I tell patients, don't worry, it's going to be fine, I know it. I mean it because I've done it before. But it really gives me, a personal perspective. I can really empathize with patients, what they're going through when they first hear the diagnosis, what they're going through when they get the biopsy, when they have the surgery, how it's like to recover from surgery. I've been there, I've been through it, so I really can help them through it. And it's not something that I tell all of my patients. I don't tell everybody, but especially the ones that are very scared, I tell them, listen, I'm fine. You're going to be fine too. So I think that provides them with a lot of comfort, seeing that I've been through it, I've done it, and I'm fine. I feel great, and I'm doing well.
Absolutely.
Yeah.
Dr. Paraskos, thank you so much for being a guest and for sharing your story. It's very inspiring. As you can see, it's not the end.
No.
Far from it. It's very curable. Be sure to join us next time on the Health Channel, All Health All the Time on South Florida PBS. Follow us on social media at All Health TV, where you can get health tips from our experts and see what's coming up on the Health Channel. Be sure to visit our website, allhealthtv.com, where you can watch a live stream of the Health Channel, submit questions for the experts, and watch videos from previous episodes. I'm Henry Guzman, and I'll see you next time.